Thank you so much. So again, we're going to talk today about the Omicron variants. We're at BA2 now, which is the second variant. We'll talk about research updates with the second booster. We'll talk about different guidelines or recommendations for that, immune protocols, and then future directions, and certainly your questions, and we'll try to provide answers or have at least a really good deep discussion about the Omicron variant and immune health. So again, this is April when we're recording this, 2022. The last one we did was January. So it's great to see everyone here. Thank you for coming in live. Thanks for watching if this is afterwards. I hope everyone is staying safe and healthy and your loved ones are safe and healthy here. I just looked at this a few minutes ago. Worldwide, we're still dealing with about 2,700 deaths daily from COVID. In the US, the 7-day average has dropped to below 400 deaths a day, which is still a lot for sure. It's lower than it has been in a long time, but this is definitely still a lot of people. In the past 7 days in the DMV area, we're getting definitely lower in terms of the number of people dying from COVID. Maryland, about 3 deaths per day, Virginia, 19 deaths, and then DC, 0, has been 0 for over a week now, which has been really good. So I guess my main conclusion here so far is that across the board, if you look at the CDC data, if you look at the metrics, cases, deaths, and hospitalizations are all down, which is a good thing. We're all grateful for that. The CDC does have a COVID-19 communities level website that the link is in the slides here. And you can go to that, you can pick your county, and you can just see what the level of risk is, essentially high, moderate, or low, depending on basically hospitalizations and I think percentage of cases that are positive and things like that. And so based on that, most counties now are low risk. There are some counties in New York, like central New York, that are high or moderate. I think that's one of the areas that's still a little hot. Indoor masking is not required in most counties per the CDC guidelines as of today. So we can talk about the SARS-CoV-2 variants. So we initially started out with the Alpha variant, then it was Gamma, then Delta, and then there were some others along the way like Beta and Lambda and all these different alphabetical variants. The Omicron then hit a couple months ago. We had BA1, but around the same time, BA2 and BA3 evolved as well. BA2 is now about 85% to 92% of cases globally. I think in the US it's about 85%. Of that, there's also a subvariant of BA2, which has been found in New York State, that also has a growth advantage over the second variant of BA2. So that's called BA2.12 and BA2.12.1. I'm getting really confused now over all the different variant lineages and the numbers and letters, but any of these variants of Omicron haven't been found to have an increase in severity. There's also what's called the Deltacron, nicknamed the Deltacron, I think, which I didn't put on here, and that hasn't been found to be getting a foothold so far, which is good. And there's also the variant XE, which is the Omicron first variant, or BA1, combined with the second variant, which is BA2. And there's a 10% growth advantage over BA2. But again, this is right now mostly in the United Kingdom without an increase in severity. These are very highly contagious, but typically not that serious in terms of hospitalizations and deaths that we're going to talk about later. And then there's actually BA3, which is not that prevalent right now. And then there's BA4 and BA5, which are the 5th and 6th variants of Omicron that are circulated in South Africa and Europe, or Southern Africa and Europe, I should say. So the important thing to know about this is that none of these variants have demonstrated an increase in severity versus the first variant of Omicron. So we're not really dealing with a completely new virus here, variant. Cases are rising in the US again based on BA2. And there's an uptick rather than a surge, I think is what's happening right now. There is a little bit of an uptick, but in terms of what we see from hospitalizations and deaths, that's considered stable or going down right now anyway. It doesn't sound like an increase in the cases has been leading to an increase in hospitalizations and deaths at this point. And so there's a few reasons why why, you know, some of the numbers could be slightly skewed. Number one, people are definitely testing more at home, and they're not reporting if they're positive or not to the, you know, state authorities, et cetera. There's also this idea of increased immunity from either vaccination or a natural infection, especially after the recent first Omicron wave. So here's some symptom comparisons. Um, Omicron is considered typically less severe than Delta. It invades the upper airways, but stops there usually doesn't go to lungs usually, whereas Delta usually often did go to lungs. So for Delta, you see that one of the big things is for Delta, people had a lot of shortness of breath, even hypoxia, low oxygen, stuff like that. You typically wouldn't see that with Omicron, with influenza virus, or with a common cold. At the same time, Delta, you had a lot of fever. Flu, you also have a lot of fever. With Omicron, fever is not as common. You will have night sweats with Omicron often. People have that. People can get a loss of smell with Omicron, but it was more common with Delta. You can see that Delta, Omicron, and flu all involve some degree of fatigue. And then the symptoms are a bit shorter with Omicron than with Delta, so you can kind of see that there. But also more people are asymptomatic with Omicron versus Delta, up to 30%, I think, are asymptomatic. And in kids, I think it's like 50%. So it's actually a lot more in kids that are asymptomatic. They might have Omicron or viral particles, but they're not actually symptomatic. Let's talk about vaccines and where we stand on boosters. Is anyone as confused as I am about all the guidelines? Everything's changing. I don't know. Let me see if I can see the chat here. How many people are completely clear about what it says for guidelines right now? Everyone is very clear, it seems. I don't know. Unclear. Okay, super confusing. Thank you. I'm confused about it. I've been trying to do the research on it, look at the CDC website. Dr. Fauci and others, the experts, are saying that everyone's kind of in agreement now that vaccines are effective at preventing against severe illness, hospitalizations, and deaths, but they're not preventing exposure to Omicron. They're not preventing mild infection, not preventing symptoms. And so the general conclusion, even from the general, public health experts now, based on the severity, and not based on the severity, based on the contagiousness of Omicron, is that anyone with Omicron infection can spread the virus to others regardless of vaccination status. And Dr. Fauci even said on ABC a week ago, he said that everyone will likely get Omicron, or everyone will likely get COVID at some point. And I think people have known about that now for the last 6 months at least. But, there is some efficacy of vaccines for reducing the risk of severe illness, hospitalization, to death. We're going to talk about second booster in a minute. CDC does recommend full vaccination for everyone over the age of 5. And if someone does get infected and wants to get a vaccine, based on general vaccine principles, the option is to wait 90 days after an infection before getting a vaccine or booster. So here's the guidelines here, which for a third shot, which is the first booster. And then you can see the guidelines for the second booster as well. So the guidelines are different than saying that you must get it or that it's recommended. So this is where it starts to differ on the second booster. Let me see if I have that on the second. I don't know if I have it on the second slide there. So I'll just say it here. The CDC is saying that for age 50 and up, and for immunocompromised people of all ages, that a second booster is an option. It's available for you. They're not recommending it officially. They're not saying you should get it. Okay, so they're just saying the second booster is available for you about 4 months after the first booster, essentially. In addition to this, on Wednesday, the ACIP, which is an outside group that advises the CDC, immunization group, they even said in their meeting that this is a very important statement here. I don't have this on the slides. ACIP said that they wouldn't necessarily recommend the second booster for everyone over the age of 50. It depends on immunocompromised status. It depends on risk-benefit analysis. So this is a very marked departure, I think, from, everyone needs to get the booster if they're over a certain age. This is not what they're saying now. So I think that's an important statement to make here. The other issue with, I think, just to consider when you're saying, who should get a second booster shot? Should I get this or not? The boosters are similar to the original formulation, so this has not changed since the variant's emergence. That means the same shots that you got in a year or two ago, in terms of the original shots, mRNA shots, let's say if you got that, they're basically the same shots. So we're going to talk about some of the future directions for vaccines in a minute. So who should get a second booster shot? It's not officially recommended. It is saying they're saying the CDC is saying you could get a second shot if you are in these categories. So who should get a second booster shot? So we're going to examine three papers, three research papers. This is where the basis for the second shot is coming from. So the first one is probably the most important. This is the New England Journal of Medicine study. And for those of you that don't know, the New England Journal is one of the top journals in the world for medicine. So this is a very respected peer-reviewed journal. This was a study in Israel. This was 180,000 pairs of people, matched pairs. So the first group of people, and they were all 60 and older. So that was the group. The case group was the group that got the second booster, and what they did was they measured vaccine effectiveness, and effectiveness meant how many hospitalizations and deaths happened, but they measured it really shortly after the booster. This was within 30 days, day 7 through 30 after the booster. So from 0 to 7, it's really not enough time for the vaccine to kick in. So they said at day 7 through 30. We're going to measure how many people get hospitalized in that second booster group, how many people die in that second booster group in this huge study. And the control group was the people that got a first booster vaccine that was given at least 4 months before the study. So again, severe COVID-19 is defined as hospitalizations or deaths. And they ended up having 120,000 people in each group. So 120,000 in the second booster group, 120,000 people in the first booster group. So basically 120,000 people got 4 shots, 120,000 people got 3 shots. They did find that there was overall less hospitalizations and deaths in the second booster group versus the control group, which is the first booster group. And you can kind of see that here. Overall, the overall rate of hospitalization and death was very low in both groups, though, and they did mention that in the study. So the link is there to the full study if you want to read that through. If you have any questions, just email us, let us know. We can chat about it more if you'd like after this webinar. So, 59 versus 205 hospitalizations, 7 deaths versus 35. These are considered, a significant reduction in hospitalizations and deaths, although in both groups, these are very low when you consider there's 120,000 people in each group. So what I think would be interesting to see is who actually got hospitalized and died in that group, what were their health conditions like and things like that. So this was matched for that, but at the same time, I think there's some question, which we're going to talk about in a minute, about, also risks of second boosters. So we can talk about that. Study number 2. So we have younger healthcare workers in Israel, effectiveness of the second booster among younger healthcare workers in Israel. So basically what happened is what they found was after a third dose, neutralizing antibodies dropped significantly after 5 months post-booster. And then the 4th dose did increase the neutralizing antibodies by about 10 times. So that was effective. But in terms of preventing infection for younger healthcare workers in Israel in this study, the effectiveness of the 4th dose was no different than the effectiveness of getting the 3rd dose alone. And either way, about 20 to 25% of the group, whether they got boosted or not, got Omicron. So this conclusion was, and this was also in the New England Journal of Medicine, in this young, healthy cohort of healthcare workers in Israel, a fourth dose of like a second booster or a fourth total shot only had quote unquote marginal benefits. Any questions about those two yet? We can chat about it. Yeah. And then number three, so third study, also from Israel. So this is a very large healthcare system in Israel called Clalet Health Services. This study has not been peer reviewed yet. Okay. Meaning other scientists, other doctors haven't looked at this yet in terms of really analyzing the validity, but preprint, non-peer reviewed study, still worth mentioning. This is people aged 60 to 100, a huge number of people, over 500,000 people, 563,000 people in this healthcare system. 58% of them got a second booster. They're all age 60 or above. Mean age was 73, and 53% of the study population was female. The study period, again, was very short. This was only during the 40 days of, post booster. 92 absolute number of people who received the second booster died, compared to 232 who only got the first booster out of 500,000 people. Okay, so yes, there was a reduction in death, 78% reduction. But again, a very low amount of people actually did die with this. So there's something called a Cox regression model in statistics, and basically it calculates a hazard ratio. And I thought this was useful to put in here. In this study from Clalet, they found that a higher age group, especially 80 or above, male sex, chronic heart failure, chronic lung disease, which is like COPD, and diabetes were significantly associated with a higher risk of death due to COVID-19. So that's the link there. So you can see how there's different health conditions that might increase someone's risk and might push someone more towards a booster, might push someone more to more precautions. We can kind of see this in these kind of studies. But overall, I think the good news in all three of these studies is that the risk of death and hospitalization for the Omicron variant of COVID, was very low across the board, whether or not they had a first booster or a second booster. So here we go into what should we do? What should you do if you're listening and you're 50 and over, or you're immunocompromised? How are you going to make your own individual decision about, weighing risk and benefits? Because the ACIP, which is a sort of unofficial arm of CDC, they're kind of saying, well, you have to make your own decision. So this is a little bit of a different guidelines than we had in the past. So how long to wait before getting revaccinated is a little bit controversial. It's a little bit like kind of have to think about it more individually, more personalized, which is what we'll talk about today. We haven't really had a situation in the past. I mean, I think for most of us that are watching this, I don't think many people of us, if anyone, has lived through the 1918 flu pandemic when the flu was new. So this whole pandemic thing is new for all of us, I think. And vaccinating every few months is a novel concept. There is a concern from many immunologists, many experts out there that vaccine boosters that are too frequent might tire out parts of the natural immune system, like the T cells and the natural killer cells. There might be actually too many proteins presented to the T cells and the natural killer cells, and this could result in something called immune system overstimulation. So if I like punch my shoulder and I tap it, a little bit, that's kind of like a massage for me, like, okay, this is pretty nice. But if I like hit it and I keep on pounding on it day after day, my shoulder might start getting sore. And in fact, my bones and, my shoulder there might be some problems, down the line. So I think we don't know if this is going to be the case or not. From a perspective of basic science, we know that Marco Cavalieri, who's the head of vaccine strategy, a very conventional organization, European Medicine Agency, said, quote unquote, recently that T cells become dysfunctional when they repeatedly see antigen in certain contexts. So I think a lot of doctors, a lot of healthcare practitioners, a lot of public health officials now are wondering, is the immune system going to get overstimulated with repeated boosters if they're too frequent? And this is something that is not known, okay? We haven't had a pandemic before. We're in year 3 now. The research on repeated vaccines at short intervals like this has not been done. So I think we have to use the precautionary principle here and just kind of take some risk and benefit analysis and kind of make an individual decision for each person, in a way. I'll get to the questions in a minute. I think we're almost through the vaccine part. How many vaccines are in the pipeline? So we're talking about Novavax is definitely in places like Europe and Asia now. It's being used. I think some of you may have gotten Novavax. If so, please put on the chat how that's been for you. This is a more traditional COVID vaccine using a piece of the spike protein plus an adjuvant. For unclear reasons, the FDA has not met to discuss approval of this vaccine in the United States. This was submitted to the US government in January of 2022, and they're sitting on it for some reason. I don't know why. I'm not going to get into the politics of that. But that is sitting there. Other places around the world are using Novavax. There's also Corbevax, which is very similar to Novavax. This is licensed for use in India, and I believe they're doing trials there in India. It was developed in Texas, actually. This is also specific to COVID-19. It uses a piece of the spike protein, et cetera. And then Pfizer and Moderna, who have the mRNA vaccines, the general ones, are aiming to have Omicron-specific vaccines by fall 2022. That's kind of the update on that. And then the other thing that I was reading about was the pan-coronavirus vaccine. So there are some trials, early trials, starting at Walter Reed right here in the DC area in January. They're using an iron-based protein with different faces, and those faces have different spike proteins from different coronaviruses attached to each phase. So they're testing that out on people right now, and that would potentially obviate the need for a Omicron specific variant if that got a little bit more widespread. So that's very early right now. It's pan coronavirus vaccine. That's something that's trying to be being developed by Walter Reed. Testing, I think we went through this last time, so I'm just gonna say in terms of rapid testing and PCR testing, those are very widely available now at pharmacies, et cetera. The second variant of Omicron does not appear to change the accuracy of testing, is what I wanted to say about that. So you can read that there. Guidelines haven't really changed since the last webinar three months ago in terms of quarantining. So the idea is you want to basically try to stay home or quarantine, if someone's tested positive for at least 5 days from the start of symptoms. After that point, testing after that is optional. You can consider testing at day 5 with a rapid antigen test. A PCR test can be positive for up to 3 months after an initial positive test, but you have to also follow the workplace and school guidelines and things like that. People have their own rules as well. So if that's negative, you can break quarantine. If you're not symptomatic, in theory, you could officially break quarantine even if you didn't do a test. So just talk to your workplace or school about that. If you're still positive and you're having symptoms, then you tend to want to quarantine longer. And it is possible, I think, for viruses to stay in the system for longer than 5 days, of course. So that's another consideration. Currently at the state or federal levels, there are no indoor mask requirements, but individual counties or businesses may vary. And now this is another change, and a sea change in terms of recommendations is that each individual can assess his or own risk and make a decision on whether or not to mask. So this is a very much of a different change than we had in the last 2 years. I think we all know about masking and, trying to get outside as much as possible, get enough fresh air and things like that. So that was the change there from the masking guidelines. Kids mostly having severe cases would be only in rare cases, I would say, in kids. People that essentially have chronic lung or heart issues and things like that. Vaccines are approved for kids over the age of or 5 and older, but up to half of kids are asymptomatic with COVID. This is another thing we talked about last time, vitamin D. Basically, vitamin D is anti-inflammatory. It promotes the synthesis of actual peptides in your body that do have a antimicrobial activity against viruses, bacteria, and fungi. We know that there's a really important role of sleep and nutrition and movement, mindset, relationship, connection, and spending enough time outside in light and nature. And that's going to all boost your immune system, going to boost your T cells, your natural killer cell count, your white count as a whole. So this is important just to emphasize. We usually say this in these webinars because this is something that typically is not promoted very well, I think, in sort of a mainstream media approach. We do think vaccines and boosters are important to talk about, but we also have to look at our own immune systems because this may not be the last pandemic, unfortunately, or virus that comes around, to us. So vitamin D does reduce what's called cytokine storm, which is more of an inflammatory chemical messaging. It does reduce that. Here's some studies that show that there's an inverse risk of mortality with rising vitamin D, starting at about, or peaking, I would say about 50 nanograms per ml. So that's typically something that we try to see here in this chart, is that there's a decreased risk of seasonal infection with SARS-CoV-2, but we also see this with other viruses as well. This is across different people, different genders, different latitudes. This is pretty universal, so I kind of like this study. So please read this study. How you reduce inflammation is one way to potentially prevent the virus from getting severe for you. Okay, so there's different ways to do that. We'll talk about medications in a minute. Interleukin-6 is a chemical messenger that helps us fight off infection, but it also is the main driver of the cytokine storm that is associated with, I would say, morbidity, mortality, maybe even risk of long COVID. So there's some ways to reduce inflammation. High fruit and vegetable content. I like broccoli sprouts for this, is good. Fish, green tea, curcumin. Selected supplements, D3 is at the top of the list there. There's different medications you can consider if you want to talk to a practitioner about that. Quit smoking and drinking, very important. Stress, depression, sleep quality, address these things as well. If you're feeling sick, and there's a lot of other things besides this that we're going to get into, but talk to your healthcare provider, go to urgent care, go to the ER. Baby aspirin may be helpful if you feel sick because it may reduce the risk of microclots. So you can talk to your provider about that. IV fluids or hydration in general, and then inhaled steroids could help with reducing inflammation. Fluvoxamine is another fairly new treatment that binds to the sigma-1 receptors on immune cells and reduces inflammation. In high-risk outpatients, it reduced the need for hospitalization by about 60%. There's also monoclonal antibodies. The newest one is called bebtelovimab, and that is available in Tacoma Park, thank you, Cass, as well as some other places in the DMV area, and that could be used for more high-risk patients as well. There's also Paxlovid, which is from Pfizer. It is a oral medication that's a 5-day course. Again, try to use it within the first 5 days of symptoms. It is a viral protease inhibitor, so it kind of reduces viral replication. So that is available now, and we are using that as well. Let's see, anything else to say about that? Usually also use that for people that are higher risk for complications, not necessary for every single person. Some natural protocols, not FDA approved for prevention and treatment. Just think about overall herbal mouthwashes just to reduce viral load. You think about high-dose vitamin D3 and C. We have different protocols for this that are still relevant, I think, here. Quercetin to help bind to the spike protein. NAC, I think, would be very helpful, and zinc. And then for the nasal passages, we like this Sinuorega, which is a oregano-based sinus rinse. That's pretty good. So you can kind of see some of the stuff here that we've mentioned before. Long COVID. I think I'll answer questions about this instead of going through this, because this is definitely something we're going to be heavily researching this year. I think a lot of people are going to be getting long COVID, unfortunately, or some degree of it. So we're going to be doing some research on this and trying to come up with some protocols so we can, hopefully provide some of the best treatments for this so people can get over this quicker, sooner rather than later. Here are some theories as to why, long COVID may be happening. This could also happen at times with vaccine reactions. We've seen this too, but uncontrolled ongoing inflammation can lead to depletion of energy in the body, which is called mitochondrial dysfunction. It can lead to microclotting in the body, autoantibody production, which is more of an autoimmune condition, and then persistent viral infection in those that are infected, various organ reservoirs, including the GI tract, gut tissue. So these are some of the possible root causes of reactions post-COVID or post-vaccine if someone has a bad reaction to that. Here are some things we think about in terms of how to treat this. You can kind of see that here. Again, these protocols are evolving over time, so I'm sure we'll be adding to this and we'll talk more about this. Blood sugar is critically important. Don't eat sugar. Monitor your blood sugar with continuous glucose monitors if you can. You want to basically reduce the viral binding to the ACE protein, which you would do by reducing sugar. So treat the diabetes, treat the hypertension, lose weight if you have excess weight, avoid alcohol, things like that, so you can regulate your immune system better and protect your immune system better. And then generally you want to also eat foods that are high in vitamin A, vitamin D, short chain fatty acids like fiber, fermented foods, things like that. So you can kind of see some of these other things here. We've talked about these for a few webinars now. So nitric oxide is important. I think the vascular system gets compromised with COVID. And so nitric oxide levels go down, the vascular system gets inflamed, microclots start happening. So there's ways to protect the endothelium, meaning the inner lining of the artery, from vascular dysfunction. You can check nitric oxide levels and you want to try to optimize those levels. And that helps keep your arteries open, which keeps blood flow going to all of your body, and your immune system can then kind of travel in any part it needs to go to with a healthy nitric oxide level and an open arterial system. So we are going to continue to look at guidelines and lifestyle nutrition. Institute for Functional Medicine has some good links here on things as well. I want to have some time for questions here. I think that's it. I'm going to stop share. Okay, we're still on. So there may be some questions. Thank you for coming today. I wanted to make sure we had some time for questions. Jen, do you want to just tell me the questions? I don't know if...
Sure. It looks like there's a question. You addressed this partly, but maybe you want to go more directly. Pros and cons of the second booster.
Yeah, I think it's individual. I think even from the public health officials, they're actually saying now that not everyone in that group of age 50 plus needs to get a second booster. So I think that was pretty revolutionary for them to say that not everyone needs to get it. You have to look at your own individual risk. You have to look at, do you have diabetes? Do you have obesity? Do you have hypertension? Do you have chronic lung disease? Do you have chronic heart disease? Do you have a risk of having severe complications from COVID? And also try to understand, did you have Omicron already, right? If you had Omicron already, it's very likely that you're much more likely to be protected and you wouldn't have a breakthrough infection even symptomatically with already having Omicron 1. So you have to look at all these kind of factors into play. I hope that answers that question. If someone is more immunocompromised, then that shifts more people towards maybe getting a second booster.
Great. There was a question about the recent mask mandate being lifted on airplanes. How much more open to possible infection will flying be? Would you recommend flying? Should we quarantine with a mask? Or should we quarantine or mask when we interact with unvaccinated young children, and for how long?
Yeah. These are great questions. I think flying is not without risks, but probably driving our cars is more risky than flying, with or without masks, I would say, depending on where you are. But I think it doesn't it doesn't make sense to not go see your grandchild or something if you feel like you're protected enough. I would, that's what I would say about it. I don't know if that makes sense or not to you, but um, I would I would weigh the risks and benefits. Some of the costs of social isolation. We actually know that connection or lack of connection is associated with morbidity and mortality as well. So you have to weigh the risks and benefits of flying versus not flying, and why are you flying? What is the reason? Is it a business trip that you can do telehealth? Maybe that's fine. Is it something where you haven't seen your family in a while and you want to do that? Um, but in terms of masking, yeah, I mean, I think you will be, relatively protected if you are wearing a mask, even if someone else is not wearing a mask and things like that.
There's a question about vitamin D. Can vitamin D levels be too high? How much to take daily?
We typically like, and everyone's a little different, but we typically like between 50 and 80 in terms of a level. It could be even a little higher than that, depending on if you have some severe autoimmune disease or something like that. The amount to take per day doesn't really matter. It's more about what your level actually is. So you have to test, not guess. A typical dose would be between 2,000 to 5,000 a day IU, but you have to test to see if it's still too low or too high. There's a lot of factors involved in why someone's level might be too low or too high. So I would actually test and answer that question that way and try to get the level between 50 and 80 for most people.
The question about talking says, can you talk a little about the blood tests you're having done for patients to check antibody levels?
There's spike protein antibodies, so that's will not differentiate between whether or not you got vaccinated or whether or not you got infected, because vaccines use the spike protein. But nucleocapsid antibodies could also be checked, and if those are positive, then you likely have gotten infected before, because that is specific to the coronavirus itself.
Can you please talk about measuring nitric oxide levels?
We use a test strip that basically you can get online. You can get from pharmacies as well, I think over the counter. It's called a salivary nitric oxide test strip. Um, and there's different brands, I would say, out there, but basically a salivary nitric oxide test strip, you can just put it on your tongue. You can see what your levels of nitric oxide are. You would want to test that out about 10 minutes, within 10 minutes of waking up, I would say, but before you drink anything or eat anything, and then you can see if your level is low or not. And if it is low, then you need to boost the nitric oxide level. And there's different ways to do that, which we can talk about. Yeah, we can talk about that. So dietary greens, green leafy veggies, beets or beetroot powder, supplements that contain beetroot powder, or sauna is another way, and then exercise is another way to increase nitric oxide.
Can you explain more about the spike proteins and the possible side effect of myocarditis?
I think that what happens is, whether or not someone gets an infection or vaccine, in theory, something called interleukin-6 gets elevated. This is uh, a substance in our bodies that we make that helps drive inflammation up so that we can fight off bugs, viruses, etc. So when interleukin-6 goes up, then that can lead to, in some cases, overinflammation if it is a prolonged elevation of that chemical messenger called IL-6, and people can get myocarditis from that. So it's not that the spike protein directly causes myocarditis, but what happens is the spike protein triggers inflammation in people, and if that inflammation is sustained, it can lead to myocarditis, inflammation of the heart muscle.
If you get the fourth booster, should you get a different brand, like switching from Pfizer to Moderna, for
I don't
example?
think there's any evidence one way or the other on that.
Let's see. So how do we access Paxlovid? When is it appropriate to use? All positive cases or some cases?
Not all positive cases. I think if you're low risk and you're not feeling badly, then I don't think you need it. But people that have more of the risk factors for severe COVID, people with diabetes, people that are overweight, or, have some sort of inflammation going on at baseline in the body, maybe have autoimmune conditions, maybe they are feeling sicker though, and having, symptoms that are not going away in the first few days. You do want to use it in the first 5 days. So I wouldn't say it's for everyone, but it is available at a fair amount of pharmacies now. So we have been able to find it at various pharmacies.
Okay. If someone's hypertension is under control through medication, are they still at heightened risk and should consider a second booster?
I think if your blood sugar and blood pressure and all that is under control, I wouldn't say you're at high risk.
Can you speak about the nasal vaccinations?
I need to do more research on that. They're not they're not out yet. I think they're being developed. I have read about it. I just don't have any slides on that. So I think we can get back to you on that. If you want to message us maybe in the portal, if you're the patient, if you're not, just message info@cihealth.org and we'll get back to you about that.
Would you recommend rapid test or PCR prior to meeting with other people indoors? Would a PCR taken a few days before a meeting provide up-to-date information?
I would do a rapid because it's quicker. It's a little bit more. Remember, PCR is going to take a couple of days to come back, so you're going to get a little bit of a backdated test. I think if you're not symptomatic, I wouldn't say you need a PCR for that.
Does one need a booster if already exposed?
No. Exposed, you mean like you got infected? Is that what you mean?
Maybe you can clarify just as exposed. Yes.
If you got infected, then no. Like recently, then you got Omicron likely, and so you wouldn't need a booster in that situation, at least not in the first, 3 to 4 months. And I would even consider probably you wouldn't need a booster with this current vaccine. That would be my thought about it. The studies on that showed that people that got BA1 only had a 5% chance of getting a breakthrough with BA2. So that, you have a 95% chance of not getting a breakthrough if you already got infected with Omicron 1.
There were some questions sent in prior. There was a question about how, actually first is, when is it safe to enter the home of people who've had COVID? How long after they home test negative should you wait to visit them in their house?
I don't think it really lives very long on surfaces. If someone wants to chime in on that. Yeah, I mean, if they've tested negative and they've been reasonable about their cleaning, I don't know that you need to wait longer than their negative test. It's sort of your own comfort level, so that's what I would say about it.
Okay, and then a question just came in. Still testing positive on an antigen test 11 days post-positive. Should you assume still contagious?
Are you symptomatic or no? Because that's... You could still be, I mean, in theory, you could still be, yeah. I think you could still be. I think there are some studies that show that people, even though we say 5 days, people are still having congestion and things like that. The symptoms could last for a couple weeks, 1 or 2 weeks or longer. And some people just have the virus for longer, in their system. And the gut is one of the major areas for reservoir, for COVID-19. So there are some people that tend to have the virus persist for a little bit longer. So I would definitely consider there, some things to help boost your immune system. You're part of doing that, but certainly things to just help, like NEC, Sino-Erega, things like that. Yeah.
And a related question, how long after testing positive with symptoms is someone contagious? So it's kind of what you just answered, but.
Okay.
And this was also addressed, but what is your perspective on the new variants and the definition of close contact, given that it is a more contagious variant?
Yeah, that's a great question. It's probably my favorite question of the entire hour here. I mean, 30% of people are asymptomatic, and it is a pretty spreadable virus. So, what is a close contact is a great question. if you're within 6 feet for 15 minutes, I think is considered close contact. But you know, how spreadable is it? I mean, it's pretty spreadable, I would say. I mean, that's why I think people are experts are saying that eventually we're all going to get COVID. We're going to get some variant of it. So I don't know if that makes any sense or not, um, but in terms of the close contact, I don't know if I answered your question. If not, just chat that again, please. Thanks.
What about if the test is negative? Sorry, what about if the test negative on antigen test and still some congestion, is the person still contagious?
The test is negative. Oh, I see. Well, you can always have a false negative test, right? And that's possible. Um, so yeah, I think it depends there on, do you have allergies? I mean, it is spring right now. Is there something else going on and it's not COVID anymore? Um, you could get a PCR, I think if the PCR was negative, I think you'd be pretty safe there with someone. But, if someone had a nasal congestion, you might want to keep your mask on and, things like that if you're around others that you might consider immunocompromised if you had nasal congestion. We usually don't see that situation that you had mentioned about a negative antigen test and still some congestion, but I would kind of treat that the same way. Do some oregano sinus rinse, NEC, things like that. See if you can get the congestion down. Treat allergies if you have that.
Household member tested positive. I'm currently experiencing symptoms, assuming I have contracted COVID. Thankfully, symptoms are manageable for both of us. We are quarantining. Is it of value for me to test to know for certain?
You have to answer that question, but uh, yes, I think it could be just because at least that way you can tell that with certainty to your loved ones so that they know. But from an official guideline perspective, you do assume you have it, and then you just kind of wait till the symptoms get better. Wait 5 days and things like that. So up to you there. Yeah. Well, I have we've definitely seen a lot of people getting COVID recently, a little bit more than before. Not as bad as the first Omicron wave, but certainly have been some. So knock on wood, people have been doing okay generally. It's been sort of more mild, I would say. So hopefully that just continues. I want to thank everyone for coming on today and hope you stay safe and healthy and enjoy the spring. And we'll keep trekking along here. Thanks for staying with us, and we'll chat with you later. Thank you all. Thank you.